So how do you treat borderline resectable liver metastasis in RAS wild-type cancers? And you should definitely not use EGFR antibodies. And I'll show you why. We actually have data on that. That's not even a debatable thing. It's because we have data. You know the importance of liver metastasis. It's one of the organs which really sometimes are the exclusively lifelong metastasis region for patients with metastatic colorectal cancer. So some patients can actually be cured with surgery, and we need to make sure that we have adequate, that we embed these patients in multidisciplinary team discussion, because this is really an important factor for patients. And surgical criteria, what is resectable, what is borderline resectable, has actually changed, and it really depends on the surgeon and your approach, how to deal with that. Now, just for the sake of definition, I'd like to give you some ideas about what are we talking about treatment in the context of liver resection. There's neoadjuvant treatment, which we define as resectable liver metastases that are being treated for various reasons. Then there is conversion chemotherapy. These are the borderline or primarily unresectable tumors. These are the ones we're actually focusing on today in our debate. And then there's postoperative adjuvant therapy, which we'll not talk about. We have known for quite some time now that compared to initially resectable liver metastasis, those patients who are made resectable with chemotherapy, those borderline resectable tumors, they can have long-term benefit too. They might not do as well, which is just a matter of biology, but they are long-term survivors, and that's why it's important. What do we expect from the ideal conversion chemotherapy? Response rate, quality of response, and less toxicity. And I'm not going to talk too much about toxicity. We can do this in our discussion perhaps, but you really want to facilitate surgery for the cancer. Now, we've seen resectability correlates with response rate, anatomical response rate. That's a paper several years ago which looked at a pooled analysis of studies looking at resectability of patients with liver-limited disease, and the higher the response rate was, the better the outcome actually seemed to be. Now, this was mainly conducted at a time when we did not use biologics, and the question of our debate is actually more biologics, bevacizumab versus cetuximab. Now, we have seen data for chemotherapy that a triplet has higher response rates than a doublet, and we've known this for quite some time. We've alluded to this earlier today when we talked about BRAF mutant tumors, a pivotal trial here from Italy, Alfredo Falcone's group, FOLFOXIRI versus FOLFIRI. 36% of patients with initially unresectable disease became resectable, liver-limited disease compared to 12%. So throwing a triplet at patients actually can make a difference. Now, with the EGFR antibodies, the data initially look quite interesting because we've seen time after time, if you have a KRAS or RAS wild-type selected patient population, the orange bars here, response rates go up in randomized clinical trials, whether it's Crystal or Prime or Opus and whatever. So response rate is higher. Now, what does it mean in the context of liver resection? We actually have a study. We have a randomized study initially designed as a phase 3 study, but cut short for various reasons, which I'll show you, which looked at chemotherapy plus minus cetuximab in KRAS and later RAS wild-type selected patient around surgery in borderline resectable/resectable tumors. So we have a phase 3 study that actually addressed this issue, conducted in the United Kingdom. And as expected, when you add cetuximab to chemotherapy, mainly oxaliplatin-based chemotherapy here, response rate went up about 5%, not as dramatic as we would like to see, but it went up 5%. Now, the impact on progression-free survival and overall survival were astounding. In this randomized trial, there was a detriment. There's a detriment in outcome. We still don't know exactly why that is. But for progression-free survival, there was a 49% increased risk of progression or death. And for overall survival, a 48% increased risk of dying in this randomized trial when he added cetuximab mainly to an oxaliplatin-based chemotherapy backbone. The study has been criticized a lot. There were letters to the editor and JCO back and forth, quality of surgery. But this is a randomized trial, the only trial data we have randomized. And there's a detriment even in RAS wild-type tumors. Now, in particular, in patients who have good prognostic factors, metachronous metastasis, smaller metastasis, fewer metastasis, those patients who actually have a higher chance to be cured, those patients had a greater detriment from EGFR antibodies than patients who were in more advanced setting. And that is, of course, a big concern. The study was actually closed early by the Data Safety Monitoring Board due to the detrimental effect. Now, this is actually quite reminiscent of data we've seen in the adjuvant setting with cetuximab in N0147, which was a KRAS wild-type patient population selected for FOLFOX plus minus cetuximab. And the data which were published in JAMA several years ago actually showed for KRAS wild-type and KRAS mutant tumors a trend or a statistically significant detriment in outcome. About a 20% increased risk of progression or recurrence after resection. We don't know exactly why that is, but there are a lot of things that we don't understand when we target micrometastasis compared to macrometastasis with EGF receptor antibodies. So what about bevacizumab? We know bevacizumab is really not the main drug to induce anatomical response. The data here of the 966 trial were presented earlier, 1,400 patient trial, chemo, FOLFOX, XELOX, plus minus bevacizumab, no higher response rate, but is anatomical response rate really the best way to assess bevacizumab's activity on liver metastasis? And I don't believe it's so. Because we've seen over and over again, and those of you who treat patients with EGF receptor antibodies and VEGF antibodies know the conversion of these metastases from a solid lesion to these more cystic appearing lesions, which don't really shrink, so RECIST doesn't really matter, but they look different. They look like cysts. Actually, it's fibrosis. And we've seen these data being utilized in new criteria to assess the efficacy of anti-VEGF therapy, in particular liver metastasis, CT morphology criteria published in JAMA in 2009. And these data were actually quite interesting because she categorized patients in 3 different groups based on exactly how the kind of the morphology of these lesions, how well delineed they are compared to the liver tissue, whether there's contrast enhancement or not. So there's something beyond just anatomical response. The quality of response might actually matter, devitalizing tumor tissue. And actually, in this analysis in JAMA, in retrospective analysis from the MD Anderson, the CT morphology criteria were much better able to predict viability of liver metastasis after resection than the traditional RECIST criteria, left morphology and right RECIST criteria. And we've seen over and over again in independent studies that the quality of response, regression grade, actually is correlated with improved outcome. It's not just RECIST that matters in terms of response, in particular with VEGF inhibitors. Now, another point, another MD Anderson analysis, which I find quite intriguing, actually thought initially too good to be true. So the left-hand side shows the reduced viability of tumor cells when you add bevacizumab to FOLFOX or capecitabine oxaliplatin. This was one thing. But then, you know, oxaliplatin induces liver injury, sinusoidal obstruction, this portal hypertension-like syndrome, and there are actually data that shows that the addition of bevacizumab can protect patients against the development of this vascular injury. And I didn't believe it this way, but there's another study, confirmatory study from Johns Hopkins, who actually showed the same thing. So initially I thought this was a Genentech marketing ploy, but it's actually something that seems to be real. So it also protects against oxaliplatin injury. And now we have clinical trials. We have Olivia trial, quite interesting, randomized trial, not Bev plus minus bevacizumab, but doublet or triplet with the conjunction with bevacizumab, 80 patients, randomized phase 2 trial, unresectable liver metastasis, liver-limited disease. And look at the response rate. Bottom line here, over 80% response rate with FOLFOXIRI bevacizumab and a 48% resection rate in initially unresectable liver metastasis. And the outcomes were quite tremendously positive for the triplet plus Bev compared to the doublet. That's not plus minus bevacizumab, but it shows you the potency of the triplet plus bevacizumab combination in this patient selection. And we have some data from the US which are not as dramatic, but also more a pooled patient population, including extrahepatic disease. The STEAM data presented at ASCO GI, FOLFOXIRI bevacizumab, clearly unresectable tumors initially, a 15% reduction, 15% R0 resection rate compared to FOLFOX Bev 6%. So triplet bevacizumab seems to be quite interesting for the BRAF mutant tumors earlier today, and some patients with liver-limited disease in terms of to induce resectability. So what are the practical consequences that I draw from all these data? Role of FOLFOX better established than FOLFOXIRI. We have more data. FOLFOXIRI is attractive. When you add biologic, I mean, there are some differences. Don't treat too long, treat appropriately until patients can be resected. If you use bevacizumab, stop therapy 6 weeks before the planned resection. And when you use if you really use cetuximab, the data are really puzzling. Combination with oxaliplatin in this perioperative setting seem to be detrimental. If you really use it, don't use it afterwards. Don't use it after the resection, the pure adjuvant setting. I think this is probably what really drives the difference. But overall, until we know exactly what went on in the new EPOCH study, EGF receptor antibodies should not necessarily be used for these borderline resectable tumors. So convergent therapy, liver metastasis, FOLFOX-Bev, FOLFOXIRI-Bev is effective, safe, no detrimental effect on oncologic outcome, and the addition of bevacizumab might protect against the oxaliplatin-mediated liver injury. Thank you very much.